Good morning. This is Katherine Marshall at the Berkley Center. I'm actually at home in Washington, D.C., but we are organizing this webinar through the Berkley Center, Georgetown University, with our colleagues at the Joint Learning Initiative and the World Faiths Development Dialogue. This is the third in a series, a continuing series of webinars that are focused on the COVID-19 emergency. We started on March 11th and had another on April 8th and 6th, and then we plan to have others focusing, for example, on other parts of the world and on other dimensions of the crisis. Today, we are focusing on Africa and particularly on three colleagues who have remarkable experience, direct living experience of what is happening in Africa. And we will be hearing from them when their presentations are finished. We will be opening, we will be answering your questions, which are going to be coming in through the question and answer box. So with that, let me turn to a remarkable friend and colleague, Sister Barbara, who is in Liberia. She lived through the Ebola crisis and is now very much involved in the COVID emergency, both as a teacher, but also as a voice within policy circles in Monrovia. And I will, without any further ado, turn over to her.
Okay, thank you, Katherine. Good morning to everyone. Let me start by saying thank you for having this. There's been a lot of, I've learned Zoom, I've learned to raise my hand, and I've learned to chat. Conversation, the topic, past experience to present realities. I'm sorry to say that the past experience has not helped the present reality, unfortunately. Very, very, very small has it helped. It's helped in the way that we, many of us in Liberia, at least for the faith-based organizations, we have PPE on hand, that's post-Ebola PPE that we've kept in our warehouses, thank God. But as far as a learning experience for the population, I'm sorry, it's just going back to almost the same scenario as we had in Ebola. Communities are very, very lost. They're very afraid. They don't understand. They think the government is wanting to make money. Community awareness programs are not going on because we've told to stay at home. So we were in, I think we're in deep trouble, at least here in Liberia. The National Public Health Institute has taken the lead. They are the incident management system on board. Most of us do not go to the Enfield station anymore. We're on virtual communication with them every day. They have a 10 o'clock every day meeting. Our cases are not so much, which tells you we're not doing what we're supposed to do. We know that testing and containment is the way to go. We just do not have the test kits, and we're not ready to contain as best as we can. It's not to say they're not trying. I think all of them are trying as best they can, but we're not pulling, to me, I would say we're not pulling the past experience in like we should be doing. They're retraining people to do tracing when they should have just pulled in all the health workers that they trained in Ebola. They are not helping private facilities and faith-based as best as they could. So thus we are going to have the problem of maternal child health mortalities. We're going to have the problem of people dying from malaria. The vaccination programs are not going on. These are realities that we keep crying every day, every day. I could go into some horrendous stories that we've already had at Catholic Hospital, but the private facilities are suffering. Again, it's not to say that they're not trying, but we could do far, far better. For us in Liberia, as you probably have read, the problem came with, I'm going to call it the big man syndrome. Politics tried to bypass all the surveillance and the emergency shutdown at the border. Politics bypassed that, and the politics bypassed being quarantined, and that's what started it in Liberia. Other than that, I think we would have contained it. But it is now person to person, and as of yesterday, we only had 60 cases, supposedly, but with something like 500 contacts that they are tracing. We have absolutely no ability to take care of any case that would shows a problem with sickness. For instance, the 6 deaths that we have are all people who had underlying problems, health problems, were sick in hospital, came to hospital very, very sick, but we have no ICU set up at all. We have at the new military hospital bedrooms that are set for cases that have been deemed positive. They are doing that, and they are quarantining the positive cases. Fortunately, our cases that we have under quarantine right now, which are close to 54, are all mild to moderate symptoms. We've had no case that has required oxygen or ventilators as of yet. We do have hotspots, and they've declared the hotspots. But what is our role as a faith-based institution? We've been told over and over again, our role is to keep our health facilities open. First, to keep our health workers safe, and to keep our health facilities open. It's a rural, right now, the rural areas are fairly safe, although there have two cases in 2 other counties, about 15 counties. The majority are in the city, in Monrovia City. In Monrovia City alone, the Catholic Church has 8 facilities, health centers and a hospital. So our role is to try to keep these open, but we're having so many challenges. Challenges, for instance, to get our health workers to the facilities. They give us a pass and they say the pass is no good. They tell us to use our ID cards to say we're registered nurses to get through, yet the securities are stopping our nurses. These are problems. I'm not sure other people are facing them, but these are our challenges. So I want to just end there, actually, because there's not much more to say. Did we learn it from Ebola? I don't think so. Are we doing community awareness the way we should? I don't think so. Is the Catholic Church trying as best as they can? Perhaps, but we could use a much more help. The Catholic hospital especially is suffering. The government is again paying attention to public, and that's going to affect us in the end. It did at the beginning, it did in Ebola until we opened our eyes, but I think we have a huge challenge. The real thing that's going for us actually is, like I said, we have PPE. At the beginning, the very first week when COVID was announced, little tentacles came out of my head. I ran and I purchased a huge amount of disinfectant, a huge amount of sanitizer. We purchased 400 boxes and all we could find of gloves, because I just sensed something's happening. So we're okay for the time being with that. But I think we're in for hard times. I want to thank you.
One quick question. In Liberia, what share of the health system does the Catholic hospitals represent? And if I recall correctly, it's not well integrated into the national system, but plays critical roles.
I think it's very low. It's something like 3% actually, if you're talking Catholic. But what happened last year, which is important for me, I should have said it, is USAID started helping an organization set up called Healthcare Federation of Liberia for private facilities. And we, the National Catholic Health Council and Mother Patern College, where I am dean, we signed up immediately. And they are representing us. The Healthcare Federation represents, in Monrovia, there are 346 health facilities. 272 are private, including 8 of our Catholic Church facilities. So you see the enormous problem here. And the Healthcare Federation is headed by a Dr. Nicole Cooper, and she may be one that you might want to interview at some point. is taking the lead for us. She's pushing ahead. She's gotten what passes we've gotten for some of our vehicles. She's gotten them. She speaks every morning for us, telling them that they're not doing what they need to do for private facilities. So that's a new scenario for us, and it's working very well.
Well, that's good news. Let me turn now to Peter Yeboah, who's speaking from Accra. He is the leader of CHAG, which is the Christian Health Association of Ghana, and also I think has insights into what's happening across the continent in other Christian health associations, which deliver a significant part of the healthcare in those countries. So Peter, we're looking for a quick sense of how you see the situation in Ghana, where the situation you're living, and particular challenges that reflect the Christian, but also the broader religious context.
Yes, thank you very much, and good afternoon, everybody. Yes, indeed, from Ghana's point of view, I would say, thankfully, or by grace of nature, we've never had epidemic of such proportion before. Like our brothers and sisters in Liberia, we have never had the Ebola type. And that context demonstrates that Ghana has not had this preparedness and response action to emergency. So at the moment we are having this exponential spike in case count. We are witnessing household cluster community spread at the moment. And what has been our response so far as Christian Health Association of Ghana, that is the second largest provider of health services with about 35% share of national contributions. So we have now aligned our interventions so far in terms of supporting government to build that response capacity to detect, contain, delay, and respond to this whole crisis. And so far, we have been involved in helping to slow and stop transmission, preventing the outbreaks, and then ensuring that we provide optimal care for all routine and COVID patients, be they suspected, probable, or confirmed, and also helping to minimize the impact of this. So what have been some of the specific activities we have been in so far? One is critical risk communication and event information. We are witnessing that the appreciation of COVID itself, people have still not realized the risk involved, and they've been seeing it on TV. It is probably becoming far more worse when certain portions of the country had this partial lockdown. You have people from the village calling you to say that, hey, this is city disease, and therefore the social distancing have not been that effective. The second activity as part of this government strategy is health facility preparedness, i.e. making sure that hospitals all over will have access to essential COVID commodities, including PPEs and equipment. We have been involved in ensuring that our facilities get the latest share we can to prepare our facilities to respond to this whole COVID pandemic, as well as public engagement with respect to contact tracing and disease and surveillance. So specifically to your question, what has been the role of the church in this whole COVID pandemic in Ghana, and what are some of the challenges that we could have? One is provision of direct healthcare, by CHAG facilities all over. Frontline health workers have been deeply involved. Our religious leaders have been giving the sermons. We have been ensuring that they remain steadfast in their provision. Two, CHAG has been collaborating with the Ministry of Health, because CHAG is recognized as an implementing agency of Ghana's Ministry of Health. So we have been attending COVID meetings and health-related whatever meeting it is. There is also an interesting experience, the interface of science and spirituality. Our religious leaders have been deeply involved in sharing clear evidence-based steps to prevent the COVID-19 pandemic at stage. Exactly what have they been doing with supporting this whole thing, that bringing the interface of science and spirituality? One, our church leaders have been advocating for physical distancing and social distancing, including handshaking, avoiding handshaking. They have been promoting the social, what I call infection prevention and control, in terms of hand washing, hygiene, use of sanitizers. They have been helping the community to accept quarantine, self-isolation, and lockdown measures. We've had one religious leader who returned from abroad and self-isolated. They have also been counseling clients to accept case management measures. So on that level, you could see collaboration with science very well. How about collaboration with political leadership? Very encouraging that the presidency established what they call National COVID Fund. And so far, you are finding religious leaders contributing money, equipment, and items. They also responded to what I call special COVID prayer session at the presidency, where all the faith leaders were there. They prayed against COVID at the initial stage, which is very great. The state has also established church-state platform on WhatsApp to see how they can partner. CHAG is on it, religious leaders are on it. And they have also been supporting distribution of food, financial support to COVID-19 patients and families affected. And you are finding these things encouraging. We are also seeing some high level of ecumenical or interfaith collaboration among faith-based actors. You have the Protestants, you have the Catholics, you have the Pentecostals coming together to do so. So some level, but then all these glamorized, positive developments are not without challenges, which I would like to highlight some of the challenges. One is that there is general lack of health facility preparedness. There is acute shortage of essential COVID supplies, and that is causing fear and panic. Healthcare workers are not really confident. They fear that they will be a source of risk to themselves and the patients at large, and that is becoming much of an issue. And we believe that this is also affecting routine services. Just yesterday, one of the largest teaching hospitals in the northern part of Ghana suspended antenatal care services to protect pregnant women. So we are getting a bit concerned that post-COVID, what happens to the general health status of the population? And then also one challenge is inequitable distribution of national COVID response resources. And it appears, I participate in most of the government committees, it appears that when resources are in, the state is particularly more interested in satisfying government health facilities first, to the detriment of CHAG facilities and other faith-based actors. And we think that this has also been reinforced by what I call the unintended effects of the church's contributions to the state. If the church at this point in time is contributing very well financially to state coffers, it means that the church is recognized as a resource base and not a needy partner. And therefore, at the policy level, when you are negotiating for your facilities, you have government officials saying that, oh, the churches, you have enough tithe money, collection money, and that is the unintended effect of really collaborating with government with resources in government coffers, other than complementing government services by filling gaps. And I'm also seeing that in our attempt to help, there is this lack of coherent faith-based preparedness and response to this whole emergency. I'm not seeing that coming together. You could see the Pentecostals contributing today. The Catholics are having their own way of doing things, all because we've never had any experience in dealing with emergencies of this nature. How do we harness and harmonize our network, our resources? I think that's a huge gap that I'm seeing very well. So moving forward, I would like to end my submission by saying that we have to look at faith-based COVID response and recovery. How do we prepare ourselves for future pandemics of this nature? And how do we institute complementary emergency response, readiness, and action in future? The case of Ghana is also a reflection of the entire continent in Africa. At the moment, the entire HAP, that is the coming together of all the CHS in Africa, are looking at one, how do we support with risk communication, community mobilization? How do we support case management by provision of essential PPEs? And how do we support contact tracing, and the rest. And one other challenge that we are also experiencing is that our key partners, you remember most faith-based actors have been dependent on our partners abroad. We are aware of the unique challenges our partners are experiencing in the UK, in the US, and therefore you have an unwritten informal policy of our friends to say that do not support our counterparts with PPEs, or because our own healthcare system are overwhelmed. And so that will be a fallout. If the American public say that you've given ventilators to CHAG, that will be a fallout. If Britain, I mean, the electors get to know that in their struggle, I mean, the British government are giving XPPEs. So overall, Ghana is learning how to readjust, and I believe that's the case of most faith-based actors all over Africa. We pause here for further questions, and thank you for the opportunity to share experiences.
Okay, thank you very much. I'm going to turn to my colleague Dave Robinson to introduce his colleague from World Vision, who's sitting in South Africa. So over to you, Dave.
Thank you, Katherine. Thank you, Peter and Sister Barbara. I'm Dave Robinson, worked with Daleen in World Vision for almost 2 decades. Daleen is a registered nurse and has been involved in the Channels of Hope approach with faith leaders, ecumenical, interfaith, multi-faith endeavor that began during the HIV/AIDS crisis in Southern Africa, where she is from, and then helped adapt the Channels of Hope methodology for maternal child health and child protection. Then I worked very closely with her in West Africa and adapting it for the Ebola response. And now she has been a trainer across the African continent, around the world, and has now adapted it to COVID-19. So I want to give Daleen a chance to explain how Channels of Hope is adjusting from lessons from the Ebola crisis and other pandemic responses into how it's being rolled out for COVID. Daleen, over to you. Thank you for all you do.
Thank you, Dave. Good morning, good afternoon, everybody. I want to start by saying that it is not really World Vision that is doing this amazing work. It is actually the community. It is the faith leaders at community level. World Vision is known as a faith-based organization, firstly, and secondly, for our partnership with religious leaders and faith actors around the world. And during our Ebola response, we have learned that by involving these faith leaders from the beginning, then we have better traction. So you have all seen in your introduction and your invitation to this call, you have seen that Katherine and Dave and others have written up 4 key areas that we need to focus on, and that is for us as an organization the same. And I want to give examples of how we have experienced this. Firstly, during the Ebola crisis, we need to be honest as an organization, we were not the first to respond. We were not even the second, but because we have implemented the Channels of Hope methodology, around our program areas, religious leaders were already involved. They were already in partnerships with us, and therefore there was already a basis of trust. Therefore, they have moved forward, and they took this responsibility on them. Firstly, we are a Christian organization, but we render services to all religions. We work with Muslims, we work with Hindus, Buddhists, we work with any religious group that is in the community. But our Channels of Hope methodology identify that the faith leaders is a natural force for good. They already have compassion, trust, and are looking out for the vulnerable. So therefore, they have experience of the pitfalls and the misconceptions that can happen in the community. So our Channels of Hope methodology take that existing knowledge, existing compassion that they have, and build into that the knowledge, we use theology, we use their own personal theology, and teach them about whatever is the specific issue that is at their community. The second point was they need to be at the table. They need to be an existing issue of trust. In Ebola, as Dave mentioned, in Sierra Leone and Liberia had strong inter-religious networks. And they have partnered in responding to civil wars and previous health crises. So these platforms, these existing platforms, were very quickly able to respond with one voice when Ebola struck. Recently, we have learned in DRC that exactly the same thing happened again. COVID started in DRC in the same week that they have released their last positive Ebola case out of the hospital. The first COVID positive person was identified in the country. So faith leaders was already mobilized to address Ebola, and therefore they could quickly step up and they could quickly do something about COVID. Secondly, because of the interrelation. Thirdly, because the interrelational partnerships and actions that faith leaders are doing, that there is an unprecedented collaboration opportunity. This is not easy, and it demands a lot of constant attention and resources. So our project model have already brought different religions together. So there's already trust amongst themselves and understanding. So, for example, in DRC, we've seen that even when the country brought in lockdown and where people were not allowed to meet face-to-face anymore, World Vision was one of the few organizations that were allowed to meet in smaller groups of up to 10 people, as long as they keep their physical or social distancing of more than 1 meter apart from each other. So because there is then that trust, also with governments and international institutions, they are starting to appreciate the role that faith leaders can play. To go back to our methodology of training, during the Channels of Hope approach, we teach them from their own scripture, from their own religious context. So Christians use the Bible, Muslims use the Quran, and we have tough stuff questions that we ask them, and then they have to find the answer for that tough stuff question within their own religious context. And they need to understand how to approach questions that can come to them. So what we have learned from Ebola helped us now. We are approaching the COVID pandemic in 3 ways. First, preparedness, where there is no lockdown yet. This is a very small window of opportunity, and there's only a very few select countries who is still in that area. In the pre-preparedness phase, we have developed quite a number of resources that will be made available to you all. And that Ruth will be able to put in the chat box for everybody. We started with a general guidance document for faith communities. We have looked at what is the key things that came out through Ebola and from the COVID experience from other countries like China, what has happened there. And we gave them examples of things that they can start to think of. So if we're going to go into lockdown, how will that affect our sermons? If we're going to go into lockdown, what will that mean for marriages, for funerals, for Christianing? And how can we prepare ourselves for that? Secondly, when you are in the crisis, when your country is in lockdown, it is crucial important to do 2 things. Number 1, follow the World Health Organization guidelines every time for everything. Even the guidelines that we have developed is in line with this, with the World Health Organization guidelines. This second thing is follow your government, your national government's guidance and prescriptions. Some countries allow people, we were joking earlier about some countries allow their people to still walk their dogs. I have 3 dogs. My dogs is so depressed because they're not allowed to walk. So it's depending on where you are, that will influence the type of activities that you still can do. For us, the main activities that we do is via electronic media, Zoom, Skype, and WhatsApp groups. Our WhatsApp groups, to give you one indication, I send out daily WhatsApps to 196 people. I've done a review about 2 weeks ago on how many of them sent out messages every day, sometimes, and never. Only the people that responded was only 28%. So 76 of them only replied. Of those that have replied, only 30% sent out messages every day. The ones that send out every day messages, they reach more than 17,000 people every day. On the second level of those that send out messages, on the second level, we've already went over 80,000. However, here's the challenges. Number one, not all your faith leaders at community level is literate. So the kind of resources that is available for them during this time is not always available. They can't access written word. They need to hear something like a podcast. Secondly, WhatsApp messages is the lowest bandwidth thing that we can reach them with. Zooms does not always work. Emails does not work. During the Ebola response in Sierra Leone, it took our trainer I'm lying, currently in DRC. We have a trainer in the field that is in lockdown that can't go back to his family in Zambia because of borders being closed. I tried to send him a PowerPoint presentation, firstly via email and then via Skype. It took him 3 days to download. And this was last week. It's not 20 years ago, it's now. Bandwidth is a real issue. The faith leaders who do have mobile phones, they struggle to have enough airtime and they struggle to have bandwidth to download videos or pictures. So it must be short, succinct messages. The third phase that we are looking is post the response. And post the response, we are looking forward to learning from all of you, because right now we are in the place where we need to learn how to cross the digital divide. We don't have answers for that because our world is so digitized. It's easy to send text messages. It's easy to send video clips. In DRC alone, 80% of all the mobile users is adult men. We are a child-focused organization. How do we reach children that is in lockdown? How do we reach children and communities that is not on mobile technology? I will stop here, but you are very welcome to ask me more clarification questions.
Thank you so much to all 3 of you. We do have a series of questions coming in, but I wanted first to ask the third partner in this, who you haven't heard from, Olivia Wilkinson, to see if she has any immediate questions or comments.
Thanks, Katherine. So hi, everyone. Yes, my name is Olivia Wilkinson. I'm the Director of Research at the Joint Learning Initiative on Faith and Local Communities. I'm very happy to be joining with Dave and Katherine in these efforts, the webinars that we've had so far and the resource repository that we have online. I'm going to, we have some very good questions, so I'm not going to take up time with my own. So I think if I go to just asking the first question that we have in the question and answers, and this was specifically directed for Sister Barbara, but I think it's probably of relevance, although various people have answered bits of it. Sister Barbara said that community awareness is not happening as it should be. And the question is, what should this be if it was happening in a better, more ideal space? And what would the hopes be for achieving this?
Is that coming to me? Am I to answer
Yes,
now?
it is. You're on.
You're on, yes.
Okay. I think where we failed, unfortunately, is we should have just opened up to communities as we did post-Ebola. And what happened was we went from being aware that we had a problem, and then they had a stay-home order. So it put everybody in their houses right away. And for us too, we're still struggling every day. The sheik who's very active with us on the Global Fund calls me every day. When are we going to start community awareness? My HIV team, who was doing the biggest community awareness during the Ebola crisis, calls me every day. When are we going to start doing community awareness? We cannot get passes for them to go out. We've tried to get to the government saying it's important to do this. It's important to do this. So I can't, until we can negotiate with the government, until they realize they've got a big problem. They're going to have a problem with people not doing what they need to do. They're definitely going to come out of their houses to go get food, that's for sure. But how do we teach them hand washing? How do we teach them social distancing? You can do these things, but stay safe. We're not able to do it. It's just a very big pity.
One of the more stunning figures that Daleen used is, which I had not realized, is that in DRC, 80% of the people with SMS capability are adult males. Is that true more broadly?
No, it differs in the different Africa countries. We did that assessment specifically for our Ebola response, which is basically still not over. But for every country, it is possible to pick that up. And all over Africa, it is more than 70% of all cell phone users are adults, and men still comprise the biggest majority. There is pockets, like in South Africa, there is huge amounts of adolescents that have phones, but it's really in the major city centers.
Let's go. We have several questions coming in. So maybe Peter, I'll put this to you, but I suspect, Daleen, you'll also have comments. Clearly there is a majority, I think we can safely say, of religious leaders, institutions, communities that are essentially buying the science and buying the public health advice. But we're also reading and hearing a lot about groups that are not, that are resisting, either insisting on holding services or rejecting or conspiracy theories or God's punishment or whatever. How do you assess that? We know it's difficult to know sort of how that's balanced, but maybe Peter, you could start us off on that.
Yes, thank you very much. I think one of the smartest thing our government did at the start was to, when they were announcing the ban on social gathering, was to mobilize key church leaders, like the president of the Catholic Bishops' Conference, the head of the Christian Council, Pentecostal Council, on national television, in social media. So it helped to legitimize legitimize the social acceptance of these, religious compliance to this. And yet there are certain fundamentalists that are in some small communities that are even claiming a cure, prayer session, and the rest that are there. So what is happening quickly is the ability of the mainline faith leaders, like the Christian Council of Ghana, Pentecostal Council, Church, and the rest, to come in to dispel, to disown these groups, and to work quickly with political leaders to disband, impose some level of, endorse a little bit of legal sanctions against them to do that. So you have those things there. And we are also seeing that one thing that's also helping is the capacity of our religious leaders to leverage the trust they have, which is the biggest social capital they have, and their unique access to social spaces. They have access to the church space, they have access to education space, to the hospital space, and also within the communities to dispel these things very well. So even though there are pockets of fundamentalists, groups that are there, but the overwhelming presence of the mainline religious leaders have helped to nip this in the bud, so much so that you have this strong attempt to counter misinformation, counter unproven claims, and then reinforce science and spirituality at a higher level. So that is what is happening to Ghana. And I think that the earlier we realize, Sister spoke of community mobilization, community awareness, the earlier we recognize the need to access or leverage the power, the trust of the faith-based actors, risk communication will always be divisive if it is spearheaded by government officials or politicians who are divisive in the way they compartmentalize the population for votes. That would be my initial reaction to this.
What about in South Africa, Daleen? Is that, what are you seeing there?
So there's two things that I want to say about this. The thing is that we need to remember that we will see gloom and doom in any emergency. It's always going to be there. That is why it is for us so important to work with faith leaders that have already been catalyzed before, faith leaders that have already been exposed to a new way of thinking. So the relationship that we have with the existing catalyzed faith leaders is characterized by trust and transparency, equity, and understanding of mutual shared behavior and goals around the well-being of the children in their community. And because of this, the guidance, for example, that we have developed also include a separate document actually on stigma and discrimination. So we use their own scripture, their own theologian understanding of their own religion, and help them to translate. Because number one, faith leaders are trusted in their communities. The member of the public don't have access or bandwidth to go and check on information. So we need to make sure that the faith leader have the correct information. So then number two, during the process of teaching them how to apply their own learning and their own knowledge within the context of creating a safer and a better environment to the well-being of the child, we help them to interpret their own scripture. So now they already have theological literacy, to call it something like that. So they understand how to apply the scripture correctly in the context. So now the messages is correct. In addition to that, what we do with our WhatsApp messages is if they share a message that is not theological sound, we have theologians who review their messages. We have of their own religion. We have correct messages. We have groups of volunteers that vet the messages. And then we give individual replies to them to say, this is the real truth. And we find that they actually follow those guidelines and that they start spreading a message of hope, of light, of empowerment. There is things that we can do.
Sister Barbara, what about Liberia and the landscape there? And I'll use that to add another question that came, which is, you have a lot of experience and imagination and you have contacts all over Liberia. Yes, everybody's locked down. Are there things that the religious leaders, either inside or outside Liberia, could be doing to mobilize that you see, or is it so difficult that it's hard to imagine anything on scale?
No, I think you're absolutely correct. I think there's a lot more they can do, but somebody has to organize it. I think that's the role of CABICOL. CABICOL is the conference of the bishops in Liberia. And I think he's started a little. I think only what we have to do as health workers is to encourage him to do it the right way. We know that's the part of the answer, but again, we only have 3 bishops. We only have 3 dioceses. But right now, even the Archbishop that's here, unfortunately, is not well. And he's pretty much semi-retired. but he went to visit Catholic Hospital yesterday, which is a good move on his part. But again, is there's a lot more we can do. The trouble is with this lockdown. You see, it's a matter of are we too late maybe in the city? We're not too late in the rural areas because they can certainly start doing something. But it's unfortunate. Yes, there's much more we can do. How to organize it would be what we have to think about, and we have to think about it fast. But Katherine, while I have the mic, I beg you, Peter, I want to suggest something very, very serious to you about your health workers. What you described with the health workers starting to have fear in order to serve the population is what we experienced at the very beginning of Ebola. All health workers were running away. They emptied the facilities. Why? Because they did not know how to protect themselves. So I would strongly encourage you to start immediately training your health workers, retrain your health workers. They need to psychologically understand what PPE is. You need to have them put it on, take it off, put it on, take it off. If it takes 100 times, they need to do it until they're comfortable. Once they're comfortable and they start working and know they will be safe, you will see the population come back to the clinics. This was extremely important. And this is where we have advantage. Guinea, Sierra Leone, Liberia, the hand washing buckets went out the first week. Nobody even had to tell them. Everybody had hand washing buckets outside their stores. The PPE that we went to the clinics, they know how to don them. They know how to doff them. They know how to put them on and off. This you have to start from scratch in Ghana. So I encourage you, train and retrain your health workers. Keep your health workers safe, and they will be of service to the population. Thanks for that opportunity.
There's a hot topic on the global agenda right now, which is the role of the World Health Organization. And one of the questions is asking essentially how you're experiencing WHO from where you are. I think all of the three of us have been involved in the guidance document that WHO has been working out. I think you have as well from where you're sitting. But what about how do you see, what is the experience with the role of WHO?
Here in Liberia, it's excellent. We were very blessed. We have a platform for that. And the WHO representative, new representative that was appointed, ironically, just 2 weeks before this all came about, Dr. Clement, was the doctor that was in Lofa all during Ebola. So we are extremely blessed in Liberia. He's doing a fantastic job. I think he has to kick butts a little more, to tell you the truth. He's trying, but of course he has to be a little political. I know that. But for us, we're very blessed with that. Our WHO rapport, I mean, every time I bring it to him, he says over and over again, sister, keep your places open. He knows the problems. So we're blessed. Thank you.
Peter, what about you? How do you experience the WHO role?
Yes, very well. I think in terms of technical direction, advice, and the rest, the WHO has been dealing mainly with the Ministry of Health, with the hope that their technical advice will trickle down to other agencies. So you have official encouragement far more with the Ministry of Health, and we believe that their input would have influenced the formulation of the COVID response action that are there. Probably it would be more helpful if they could also strengthen their collaboration with faith-based actors at a level that would complement the entire health system. So I wouldn't say we are probably far too blessed like Liberia. I probably think that it is a pointer for the WHO to also strengthen their collaboration far more beyond the borders of Ministry of Health and the government agencies. That is what I would really say for now. I guess that is a pointer for, faith-based actors and how we could really strengthen our collaboration with world bodies in such response, in such national health emergency response.
Dave, we have a question for Daleen that basically is about motivation and momentum. I wondered if you could frame that within the Channels of Hope context.
Yeah, Daleen, could you explain how in the the theological frames around scientific biomedical information is often dealt with in terms of motivational and for clarification for faith leaders. And the whole idea of becoming a channel of hope, the catalytic challenge of how does one kind of become a source of hope.
So I need to take it one step back. Normally in development work, we find that, and all of us, we find very often that faith leaders can be a hindrance or an obstacle. Meaning that, for example, let's take something easy. The government decide that they're going to bring in humanization and everybody needs to be humanized. I might be a faith leader and I have a small child and I have read, because I'm a faith leader, I'm a bit more learned than the general population, and I've read somewhere that it will not be good for my child to be humanized. So now my message to my congregation is going to be, don't do this, it's not a good thing. But when we build the capacity of the faith leader, we build the capacity around the specific issue at hand. And we help them to understand, what does my theology say about this? About my dogs, apologize for that. Anyway, so to come back to the point, what I'm trying to make, we use, we call it tough stuff. For example, let me take an easier example. In Channels of Hope for HIV, in the HIV epidemic, we know that one of the key things that prevent the epidemic from being transmitted is a comprehensive HIV/AIDS program, which include condoms. So what does my religion say about condoms, for example? That's a very contextual issue. We all know different stories about it. So we call that a tough stuff, and we allow them a safe space where they can debate it within their own faith, so that they can come to a common understanding, what does it mean for us? And we distinguish between lawful behavior according to my belief system. In other words, a lawful behavior, for example, will be that I will only have sex within a legal marriage. And safe behavior, meaning I will have sex with a condom. So we unpack the different levels for them so that they can understand in each and every condition or each and every step of the way how they will approach it. So all the way from condoms now to the COVID situation is that, number one, the Bible tells me, the Quran tells me that I need to give the Caesar what the Caesar is due. In other words, all religions say that you need to honor whoever you have selected to be your head. So what do we find in governments? Very often, an epidemic or a pandemic like in COVID case, it becomes a political minefield. It is so easy to cast blame. And we teach our faith leaders to say, what is the responsible thing to do? Not to look for blame. It doesn't matter why there is a snake on my table now. Am I going to have a discussion with the snake and say to him, why are you here? Where do you come from? And who's your mother or father? Or am I going to get rid of the snake? So the responsible thing for the faith leader is to address the issue and leave governments to do government's work and focus on what is the role of me as a responsible religious leader. Firstly, I must not create fear. I must not condemn my community or my congregation. And I can pray for them. But what is the first thing that I should do? The first thing that I should do is I must make sure, and I don't say I can pray, I must pray for my congregation, yes. But the first thing that I must do is I must make sure that I have the correct information to protect myself and my loved ones. Secondly, I must make sure that during my normal work, I do not put any of my congregants at risk. So how will I adjust my normal practices to protect my congregants, to help them in their day-to-day life so that they will not be at risk? And then the third step is, how do I spread this information to my whole community? So that is the basis of this. Is that good enough, Dave, or did I leave something out that you want me to add?
I think we're coming towards the end, and there are at least two questions that I want to make sure that we get in. There also are some resources that are being posted on the chat box, and we will also make sure that they're available afterwards. So first comes from India, where there's a description of health workers actually being attacked when they're coming in to try to deal with the COVID threat or the people who are actually infected. And I know that during the Ebola crisis, that was an issue, because of the trust issue. But Sister Barbara, I wondered, are you seeing any of that, or in the countries that have been afflicted with the Ebola, has that been overcome?
Yeah, thank you. That's a good question. No, right now in Liberia, it's the opposite. They know health workers are part of the solution, because during Ebola, that's what happened. So people who have not gone through Ebola, I can understand it, because during Ebola, they chased them, they stigmatized them. It was terrible. But right now, they know, which is what you see in all the rest of the world, isn't it? How you see from America and UK. Right now, they respect health workers. The security is having a little trouble, because like the president said, if you're a healthcare worker and you have your license, you get into any car, no one should stop you. So I think we're the opposite. Thank you. Well,
the final question I think that we'll have time for goes to Peter, and it comes from Jean-François de Lavizon, who we all know. And it is asking you to step back a little bit, that you're a key figure within Ghana's public health system. But if you were looking to the roles that religious actors play in public health and in basically improving public health, what are the areas that you think need more focus, or where there could be action?
Yes, I think that is a very, very good question. I think I've always held a belief that where faith is formed and informed by technical professional advice, it becomes the voice of God. So I believe that one of the ways would also be to support our faith leaders on sound technical advice to aid their judgment and their intervention in this whole area. Number one, so that they can be critical actors in this whole community mobilization, like risk communication and other engagement. And I also think that with a wider network of faith-based actors, remember, they have already said they have access to developmental space, social space. If we could entrust them with resources, because over the years they have demonstrated stewardship, they have demonstrated trust, and in times of crisis, they serve as buffer and resilience when government systems break down. So in this whole COVID response, you have partners giving resources only to government with its own risk. If faith-based actors could be resourced with information and other needed logistics, their impact could be phenomenal. I have seen it at first hand. I have seen their wider network, the trust, the relationship they have, and the voluntary submission to the authority that are there. So information resources would indeed complement and leverage the unique social assets that our faith-based actors have. It is time for the world to turn their attention on faith-based actors. We know what they did in Kenya with HIV. We know what they did in Liberia, in Sierra Leone, in Uganda. And now is the time to recognize the role of faith-based actors in addressing stigma, discrimination, harnessing their wider social network in this whole COVID response.
Well, I have a sense that we're really just getting started on a wonderful set of exchange and exploration of what is clearly a complicated and evolving situation. And it's been very valuable to all of us to hear your your experience, but also your wisdom, and to see the ways in which I think it interacts among different countries and poses, I think, some very real challenges that we'll need to be looking to the future. So this, as I said in the beginning, we see as one of a series of consultations. We hope very much to keep in touch with all of you. Thank you very much to our audience for your good questions. We didn't get to all of them, but we got to a lot. The video of this meeting will be available soon, posted on the website, but also available, obviously, by other means. We're not quite sure of the date of the next meeting, but it will be soon. And we're hoping even to be able to hear questions, but that takes us a technical step a little bit further. So thank you first very much to my partners, Olivia and Dave. Thank you to our technical backstoppers who make it happen, Ruth and Shimeng in particular, and especially to Daleen, Peter, and Sister Barbara, who are very valued and trusted collaborators, partners. We wish you well and hope that we can continue the conversation. So thank you very much.